colleagues, distinguished ladies and gentlemen, on behalf of the Paediatric Association of Nigeria, I want to warmly welcome you to our March 2026 webinar. This webinar is in collaboration with the University of Abuja Teaching Hospital. And today, we're going to learn something new. So the topic for today is integration of child life practice in pediatric healthcare, supporting children and families. I'm sure each of us in our various ways we've been practicing this, but not in the structured manner as we're going to learn today. And it's also an important occasion for us because today we have what we may call external presenters because they are non-Nigerians and we're going to tap from their wealth of experience. So it's my pleasure to welcome Dr. Livingston and Elizabeth Kabuthi as our presenters, and Micaella Jorge, who is the moderator, along with Dr. Uduak Offiong, who is also examining right now, because as at now that I'm talking to you, we're also having our postgraduate exams going on in Abuja, Lagos, and Accra. So we expect more people will join as we tag along. So without much ado, I'd like to hand over to the PAN president, ably represented by the PAN secretary, to take over the proceedings. Over to you, Madam Secretary.
Thank you, PE. Thank you for that warm welcome. So I'm standing on behalf of the president of Paediatric Association of Nigeria, and I want to welcome our speakers. Thank you for sharing your wealth of knowledge. And our PAN members, thank you for logging into this seminar with how busy today has been. And the topic is on child life. And we're talking, the essence of having child life specialists is that they incorporate evidence-based practice within the pediatric care. And if you remember our last PANCOF, we're talking about how we need to make our practice more sensitive, in tune with the needs of the child. So this is actually in line with one of the observations we noticed in our practice in Nigeria. So they are here to teach us how to support children and their family as they navigate chronic illnesses, just make our healthcare more holistic from where I'm standing. So it's not totally new, but having specialists organize it in a way that we can learn better, I think it's something interesting for us to incorporate. So over to you, our moderator. I think it's Micaella.
Thank you.
To take over. Yeah, thank you.
Let me share my screen. Okay, good afternoon, everyone. My name is Micaella Jorge, and I am a program manager at BioVentures for Global Health, or BVGH for short, which is a Seattle-based nonprofit in the United States focused on improving outcomes for cancer patients in Africa. Through our African Access Initiative program, we partner with hospitals across the continent to support their cancer care priorities, including developing targeted training programs for healthcare professionals. I'm pleased to be moderating the session today and to introduce our speakers, Ms. Morgan Livingstone and Ms. Elizabeth Kabuthi, whom I've had the pleasure of working with on a recent child life practice training for the University of Abuja Teaching Hospital, one of BVGH's partner hospitals in Nigeria, which successfully concluded just last week. Ms. Morgan Livingstone is a certified child life specialist with more than 25 years of experience supporting children and young people with cancer. She serves as the Child Life Officer for World Eye Cancer Hope, travels internationally to educate and train healthcare providers, and helps establish sustainable child life programs in low and middle income settings. She is passionate about delivering enriched programs for children of all ages and contributing to global child life advocacy and research. Ms. Elizabeth Kabuthi is a certified child life specialist and child life program lead at Moi Teaching and Referral Hospital in Kenya. She is among one of the first certified child life specialists in Kenya and Africa, leads national efforts to advance child life practice, and has presented on child life strategies at regional and international forums. Ms. Kabuthi is passionate about supporting children and families through play-based interventions, coping strategies, and holistic care across healthcare settings. Thank you so much for being here today. I will pass it over to you, Ms. Livingstone.
Hello, everyone. Let me just get ready to share my screen. And there we go. Okay. Everyone can see all right? Okay, great. It's lovely to meet everyone. I'm very excited to be here and to share the role of child life in healthcare and these child and family-friendly practices that we employ in our work that better support children's overall coping with the healthcare experience. Let me just get, there we go. You had a wonderful introduction from Micaella. Thank you so much for that, Micaella. And thank you so much, everyone, for having us. I know it's late for you guys and you have a lot on your plate, but I'm absolutely thrilled to be here. I do work all around the world in a variety of settings. I've been working with Elizabeth Kabuthi for almost 20 years now. And I'm proud to say that she is my partner in Kenya in creating bigger and better and more child life across all of the continent of Africa. I live in Canada. I'm here in Toronto right now running a cardiac clinic with 25 children this morning. So it's been a busy morning for me, but I'm absolutely thrilled to be here. There are some pictures of me here in Kenya and in Colombia and in the Middle East, where I do a significant amount of work building capacity for more child life and better supports for kids, whether it's healthcare related or trauma related. A lot of my work in the Middle East lately has been around burn supports for children that have been injured in the conflicts in that region over the last 10 years. I tend to wear funny headbands, anything to get the kids to look at me. I'm always colorful and covered in buttons, but my role is really to offer the science of child life and what we need to do to help children be and feel successful more in their healthcare experience. So let's work a little bit about what is child life. At the basest statement, child life are experts in children's development, and we work very hard to ensure that life remains as normal as possible in the abnormal healthcare environment and other challenging settings. My job and Liz's job is to promote effective coping through play, supporting self-expression activities and age-appropriate medical preparation and education. I work really strongly as an advocate, not only for the child, but for the family and the healthcare team so that we can improve the overall healthcare experience in partnership. I will always want, and at the forefront of everything I do, is thinking about what we need to do to meet the needs of children and their families. That, of course, means emotional, developmental, and cultural needs because everyone's family has a unique culture. In this picture, you have a quick snapshot of me doing some specialized medical play with children with retinoblastoma. We're looking at some of the toys and the equipment that relate to eye examinations. And you can see here that these children are not stressed. And I think the most beautiful part of child life that both Liz and I are proud of is the fact that when you deliver real, accurate, as well as pretend medical play, children gain confidence. And we're going to look at more pictures. I really want to show you what that means and how we use play to help children understand the healthcare experience. So you've heard a little overview of the role, those developmentally appropriate information and preparation for experiences like medical procedures. We deliver things like medical play, which is a safe way to introduce what the steps might be in a procedure. For example, I'm in the cardiac clinic today, and a lot of that involves echoes and ECGs. So echocardiograms and ECGs, where a number of stickers may be placed on a child's chest. So playfully and through song and pretend, we will often help children be and feel successful during the application of 10 different stickers and making sure that the assessment and having them stay still is completed without sedation. So my expertise here is in a setting where we have children with cardiac issues and challenges and needing surgery, pre and post, we are constantly doing assessments, and we do all of that without sedation. But overall, our coping support, the diversional activities and distractions that we offer, all facilitated through comfort positions, provide the emotional support that the kids need to be comfortable and to complete these assessments in as little time as possible and with as little additional people as possible. I advocate strongly for the psychosocial matters that impact children and youth, of course, in the healthcare experience. And we offer a ton of pain management strategies without medications. So there's a number of different specialized pain management strategies with no pharmacologicals. And then grief and bereavement support. We know that grief is not linear, that it is diverse and wide-ranging, and grief may even begin before a person has died. So we do a significant amount of grief and bereavement support when there is an end-of-life issue or challenge. So play is at the core of everything we do. Play is the language of children. And both Liz and I are huge players. We are the first people on the ground playing with children and encouraging them to explore their world through play. We use play to support children's coping. So just as a normalizing quality, we use it for preparation. As you can see here, my fabulous Barbie has just received a very large cast and is often used to help children understand what the casting material will look like in our emergency department. Also use play as a means to support pain management, to support children's healthy expression of feelings, and of course, to promote that sense of normalcy in the abnormal hospital environment. So let's take a brief moment and think about what you might learn about a child in your practices in pediatrics, engaging in play. If anyone wants, you can unmute and shout out a little bit about what you can learn about a child while you engage in play with them, or you can pop it into the chat and Micaella, Liz, and I can read that out loud. Anyone, can you think about, I mean, I can tell you a lot about what I learn from children during play. For example, this morning, one of my patients speaks no English. He's a Greek child and he is being raised by his mom at home, not in an early childhood program or daycare. He's only 3 and he had an echo, he had an ECG, and he also had just an assessment with the doctor. And so in doing all of that, he was nervous and acting out a little bit, you know, hitting his mom, trying to get her attention, trying to do things. And they needed my help helping him remain calm. We were able to complete all of his assessments through playful interactions across that language barrier with no issues. And it was an effective way to get him through these very abnormal assessments that a child has to have during their cardiac visit. So in play with him, what we did was we did a special positive touch activity where I did a song in his palm and then he mimicked in my palm, and so went back and forth, and I was able to see that he was intelligent, he was able to calm when appropriately soothed, and that he was incredibly bright because we were able to learn each other's languages at the same time while we were playing. Fears and apprehensions. I see Professor Becky has given us a statement here. You can always find the fears and apprehensions. You, in responding to a child's fears or apprehensions, can also help them to see that the stethoscope that you're about to use isn't painful or harmful. In fact, you can encourage them to explore it. And that's what we did today with our little friend. Their coping mechanisms. Yes, so sometimes children might show you how they cope. And for some children, that might be crying. And for other children, it might be, talking about something that they really like or they're passionate about. It might be having a hug from a parent or a caregiver. I like the patience because, yes, learning how patient a child can be in different settings can be really hard. We never know how long a child has been waiting, but I think that through play, we are able to delay satisfaction. We are able to learn if children can wait, to be rewarded. I often will use a first then. First we have to take your jacket off, and then I can give you your craft kit to make. So we'll often do special activities like that. But this is great. Let's continue on. There we go. So supporting treatment goals. I think for a lot of people in the Department of Pediatrics and in pediatrics always are struggling with and or challenged by making sure that children are able to complete their treatment goals. Whether that means taking oral medications, whether that means doing, for a child with cystic fibrosis, doing breathing activities. We're constantly helping children understand the importance of following through on their treatments. So as a child life specialist, we often use creative and play-based approaches to help patients achieve these treatment goals. Fluid intake for a child who's dehydrated, or a child who's extremely constipated. Walking, after surgery, deep breathing, vitals, coping, all of those things. We'll often use games and reward strategies to playfully encourage children to complete these treatment goals. And you can see board games are enlisted, rewards charts are enlisted, all sorts of fun and games that help us to successfully move through treatment. I think one of the nicest things too about Child Life is that we're constantly creating resources and we're constantly sharing those resources with each other. So that's another wonderful, joyful part of the process is that we acknowledge that every child is different. We're able to kind of adapt these wonderful, playful goals templates to customize for a child's needs. So play in these pictures is used to help children grow, develop, and experience that normalcy in the hospital. I think that my biggest concern, and I'm sure you'll all agree, is when I see a child who cannot play. When a child is so scared, so in pain, so challenged by their healthcare experience that they can't play, those are the children I'm most concerned with because play comes naturally to children. So here we have an electronic chick that just hatched out of an egg and we have some children exploring it. We have a wonderful block activity and a building iPad app that a child in Kenya is using with our Child Life team. Liz and I incorporate not only like functional toys and play at the bedside in Kenya, but also iPads and a really wide range of technology. And then in the lower corner, you have a patient that's just waiting for surgery in the northern region of Colombia. He's one of the YU tribe, and he's playing just outside a quiet tented area with some cars, trucks, and blocks. And you can see, again, these children are not stressed. The picture with that fuzzy little chick is taken in the emergency department in Kenya at Moi Teaching and Referral Hospital, and we even embed play in the emergency department. Whether an inpatient, whether you're a surgical patient, whether you're a child in trauma, there's always play that is accessible. Here we have group play that we facilitate too. These are some pictures of the Kenyan Child Life program. On the left, you'll see a group we play. So there are children playing a joint video game, and they are taking turns, they're cooperating, and they're having fun cheering each other on. This is something that is provided daily as a part of the Child Life programming. And we are always so thrilled to see this wonderful, joyful expression of togetherness in our classroom and play. On the other side, we have group Jenga, which of course is a real hit with children of all ages because it has a wonderful concept. And these are just play for play's sake. These are kids in the hospital, inpatients that are taking a break from their healthcare experience and just joyfully playing with each other. And the smiles tell that story of the success of these play-based programs. Now, supporting a child's coping is kind of the foundation of Child Life. In addition to play, that facilitation of coping, whether how we assess the child, the family, the illness, and the environmental variables that impact a child's ability to cope, how we prepare them through play, using medical play, using practice, and then these supportive strategies that help implement kind of the whole healthcare experiences and the changes, and then the opportunities to practice. So when we have a child that's having an ECG, we have a little stuffed bear that has the ECG leads, and the child can help apply the stickers and connect the leads. So the child understands that the leads will not hurt their body and hurt them in any way. So these opportunities to practice continue well beyond our setting. We have preparation books. We make sure that they're available to families. And those storybooks, these social stories, also allow children to understand the steps and build their coping strategies in all of their healthcare experience. Now, this picture here is one of the ones that I'm most proud of because it represents what we want, right? That improved coping. This is a child about to have a branula. He has this positive distraction that he's selected. He's sitting with support from his caregiver just behind him, and he's calmly distracted by this wonderful special meteor storm, lightning in a little ball, and you can see he's coping well. I think that one of the most beautiful things is that as we continue to build our practices as professionals and working directly with patients, we're always learning more ways to help support them. But a light up toy like this is something so simple but has such a big impact. Here we have the many different factors that influence a child's perspective in the healthcare experience and their coping. Their age, their coping style. There are many children that are avoidant and need to look away and have a distraction, but there's also a similar amount of children that are vigilant and need to watch. So we will often find, people on the medical team will be like, you need to look away, and they try to turn a child's face away from the procedure, whether it's a blood draw, whether it's a branula that's being placed, whether it's a dressing change. But some children, just like us adults, some children need to watch in order to know what's happening and to prepare themselves and to be ready to take a deep breath. So I will often assess beforehand, just like I'm hearing everyone here knows, I will assess beforehand, is this an avoidant child who likes to look away, or is this a vigilant child that needs to look? And then making sure that we ensure that the space is safe and that the child's needs and their coping style is supported. Parental anxiety has a very large part of an impact and can influence a child's perspective and their coping. A child may be perfectly all right interacting with the healthcare team and may be perfectly accepting of, a medication being delivered, but a parent might step in and say they can't do that. And the child immediately stops. What was about to be a successful procedure stops and changes when a parent says they can't do this. So I will often work directly with the child to try my best to support their needs and then reduce parental anxiety through the same kinds of explanations that I give to the child. Diagnosis variables, of course, are different. We know that can influence the child and their overall coping. Many variables also are impacted by the region and the level of ability for us to treat that illness. So sometimes there may be issues and challenges with retinoblastoma is a specialized cancer that I work with, and there may not be the advanced care needs available at every setting. And so sometimes the diagnosis demands that the child be transferred to another setting. So our child life mind prepares them as best as we can, and then we move them on to the next hospital or next referral source. The developmental level we know can change very much. So when we have different special needs, there are some children who also may have developmental delays based on their illness or their diagnosis. And so we always want to constantly adjust the coping and our expectations for the patient based on their developmental level. Temperament can be very interesting. A child with a calm temperament may be something that we all hope for, but I also love those children with lively temperaments that are very engaged and excited to take part in everything too. So those can affect, of course, and influence a child's perspective and their coping during healthcare. The number of invasive procedures, cumulatively, if we're not providing the right support, can have a big impact on a child's ability to cope. I also feel like the number of invasive procedures that are administered to a child when they're very young, maybe when they're not actively able to play, like under 2 years of age, can also have a big impact because we tend to provide less support at that age and stage of development. And I'm trying to change that. I'm working very hard. I was just at the International Society of Ocular Oncology advocating strongly for us to implement improved supports for infants with retinoblastoma because they are not receiving enough support, and it can have an impact on their ability to cope and survive and thrive later in their life. And of course, previous healthcare experiences. So let's take a minute and reflect on the health healthcare environment. I see that there was a chat question. Sorry, 1 second.
No questions right now.
Oh, it's Felix. Okay, welcome, Felix. Thinking about the healthcare environment, the sights, the sounds, the smells, how bright it is. I mean, I'm in a very bright room right now. Think about your own personal and professional experiences. What were some of your fears? What experiences have you had with medical professionals up to this point in your life? And were they negative? Were they positive? As you're thinking about this, I want to share that when I was very young, 5 years old, I actually have a picture of myself right here. This is me when I was 5, and I had my tonsils removed, ear, nose, and throat surgery, tonsils and adenoids. And I distinctly remember that it was a very bright environment. I remember the feeling of the gown on my skin and the funny socks that they made me wear while I was waiting to go into theater. And I remember playing with a Barbie doll. And I remember all of these positive parts of the experience because they stood out and I was provided with play. So I don't remember the bright lights and the big table of the operating room, and I don't remember any funny smells, but I do remember the play that I was offered. So it's remarkable what we can remember, even from many, many years ago. I mean, I'm not 5 anymore, that's for sure, guys, but I remember this very clearly in my mind, and it was a positive experience because I was provided with play. Is there anything that you can think about? The funny smells in the hospital, like the cleaning solution, the bright lights, the weird sounds, like the beeps of machines, all of that can cause fear in young children. It can cause fear in adults. And I want to respect that, that if you are able to reflect on your own experiences and what you liked or didn't like in your own medical experience, you can imagine what it's like for someone who's new to the world and has only a few years of life. And of course, you can understand that they might have some challenges with that healthcare experience. Let's take a look at comfort during care. Oh, let's see. There's a chat. Yes, thank you, Micaella. Feel free. If anyone wants, I mean, pop in, take your microphone out. But I'm happy to keep chatting and take more questions at the end if that's easier for everyone. Comfort during care is a wonderful part of child life. Comfort positions and the way that we help children ensure that the experience is as positive as possible through a comfortable hold that also keeps them safe is very important. And we will often adapt the position a child is in to help support their needs in addition to the professional completing a task. So there's a picture here at the top that is our child life team supporting a medical position called a hug and hold position, where we have our medical play doll having a distraction off to the side, who's hugging and holding the child in a safe position so that the nursing team is able to access the arm and administer a vaccine. Below that, you can see a child who's just completed a fairly painful burn dressing change, who is coloring an active coloring page with the support of a child life specialist after a dressing change. These after the comfort position, in a nice relaxing pose that supports play is a wonderful way to ensure that we reduce environmental stressors, that we manage the pain and the positioning, and that it's done in an age-appropriate way. In the corner here, you have a pediatrician who's actually looking at a mom and her child and is listening to his lungs as he's drifted off to sleep, because all of the assessments that the pediatrician was doing with this young child who had a respiratory illness and is being considered for surgery. There needed to be some good listening. We didn't disrupt the child. We adapted to meet the needs of the child in that moment, and he remained sleeping through the whole examination. But these comfortable poses, really, I challenge all of you to think about, how can I do what I need to do, or how can I assess in a way that is comforting and supportive to this child? That also can be when a child's eyes need to be inspected, when a part of their body needs to be looked at in the emergency department. There's many ways that we can challenge ourselves to look at comfort positions, and Liz and our team in Kenya have created wonderful educational posters that are available and posted all around the hospital that encourage families and our practitioners to adapt and offer comfort positions. Here's these wonderful, joyful pictures that I love so much of preparing children for surgeries, preparing children for examinations, preparing children for vaccinations, whatever it might be in the healthcare experience through play. So in the largest picture here, you have a child that's looking through one of the preparation books that takes them through each step. Every page is a story about their surgical journey and where they will go, who they will see, and what everything will look like in their surgical experience. This can be administered or are offered to children well before their surgery so that they can have that sense of mastery, so they can take time to learn, or it can even be offered the day of their surgery and just familiarize the child with what they'll see and who they'll meet during their surgery. You can see too, he's practicing, this little patient, with the sedation mask, giving children an opportunity in a non-threatening way to explore what the feeling of the mask is on their face, to hold it in their hands and explore it, can really change a child's experience of their anesthesia mask. Similarly, when I have children that have to have frequent examinations under anesthesia, we'll often use the mask in a novel and playful way, not just in practicing the deep breathing, but also in play. We'll dip the front of it in bubbles, and by putting the mask on their face, the child can blow bubbles. And this changes the relationship with the mask and makes it even more playful and even more motivating and fun for a child to put on their face. So when I've had infants and toddlers and preschoolers that have had to have frequent examinations under anesthesia, and the mask might be stressful for them, it might be something that causes distress, we will use it in this playful way to just change the experience. The mix of real and pretend is really important. So here's a deeper look at the procedural prep. We will often use real and then pretend equipment. There's a picture of my intern, Jocelyn, and I as we prepare a child for surgery using a puppet. So you'll see that we are modeling what the team will look like with their hair covered for the theater. And we are also ensuring that the patient in this playful way gets to see the puppet go through each of the steps of the procedure. There's also some small bits that have been created here in Canada that are meant to be played with and explored, just like the hospital equipment and the different types of diagnoses. So this layered approach, the photos, the books, the hands-on exploration of the materials, the videos and different materials that we often use through even apps now, virtual reality apps that help children see what the OR will look like in a 360-degree view. All of this layered approach to learning helps children understand all aspects of the surgery, and it kind of dispels misunderstandings and helps children really explore all of the different things that they will experience during their surgery or a specific procedure. This also provides us an opportunity to practice and implement their coping strategies. So for children that I know have to have a laceration repair on their head, we'll often practice the wrapping. So we'll wrap their body safely, which is really a containment hold, but in a comfortable and safe way. We'll do it playfully, and we'll practice. We'll practice what it's like to stay still like a statue, or for some children who are still very creative and into magical thinking, we'll talk about laying still like a caterpillar in a cocoon. And when the procedure is done, we'll come out like a beautiful butterfly. So all of these wonderful playful approaches really can make it a positive impact. Patient education. So looking at and exploring the body, this is what allows us to dispel those myths and misunderstandings. For many children that have surgery, they may not understand that their body is well supported and well sustained during their surgery. I've had many children with amputations or surgeries that are worried that all the blood in their body will come out. And it's usually only through play that we are able to assess what children think and are worried about, and then we can clarify and correct that misinformation. So by playing, by exploring, by doing things like this wonderful puzzle here and practicing, we can help assess and clarify and ensure that children really understand what's going to happen. This is a wonderful free resource for those of you that have an Apple device. I don't believe this is available on Android yet, but Simply Saying is a free app that is available that includes pictures. It includes animations and illustrations that you can interact with, and it also includes things like sounds of medical equipment. This is a really wonderful app that I use frequently, almost every single day. But it shows inside the body. It allows you to draw if you're concerned about a child's understanding of surgery. You can draw on the part that's going to be removed or changed or adapted. It's a really wonderful tool that I find very helpful in my practice. Let me just quickly check the chat. There we go. Yes, there you go. Thank you so much, Micaella. I appreciate that so much. If you didn't get the QR code, Micaella has put the link to that app in the chat. If you were a child, let's take a moment again to think about using your imagination and that kind of imaginative thinking, and consider what you might in your mind if you heard adults using these words. Flush, shot, dressing change, stretchers, CAT scans, stool samples, blood draws, IVs, brannulas. What does this mean? It isn't done or even considered in a language that children know. So can you imagine what their minds are thinking when they hear these words? What would they think if you heard the word CAT scan with no clarification? They would think you were going to scan their cat, probably, right? Or that they might turn into a cat if they go in a scanner. So we always want to be thoughtful about the words that we use and how we use them, because children have magical thinking. They might be scared. Yeah, absolutely. You're right, Yvonne. Kids might be scared. They also just might be really confused. There is, I mean, a ton of great information out there about different things, but if we're not giving them the information and we're just assuming that they understand what we're talking about, it can be really hard. Addressing change, there's been a time my burn practice where a young boy was like, when am I going to get my dress? I've never wanted one, but I keep hearing about this dress I'm going to get. And I had to help clarify that there's no dress, that it's just the bandages. And so we have to constantly challenge ourselves to think about what is a child thinking? What are they saying? Even an X-ray, what does that mean to them? They don't understand. But we have to explain that an X-ray takes photos of the inside of your body and doesn't even touch your body when we're doing it. It's just a way for us to see inside your body, to see if the bones and the organs and everything on the inside is looking okay. One voice is a practice that Liz and I use regularly, which is that idea of, like, if we were to dim the lights, if we were to quiet the space and have only one voice during a child's procedure or some kind of S is only used during the procedure. We need the family involved. We educate the patient before the procedure, validate the child with words. We need to offer our most comfortable, non-threatening position. That's that comfort position again, if possible, and individualize your game plan. Not every child is the same, and we need to be appropriate in thinking about that. And of course, choosing an appropriate distraction and eliminating unnecessary people that are not involved. So when I say eliminate, I really mean that. If there is someone in the room that is not contributing to the child's needs at this moment, so that might, for example, be one of my interns who wants to observe. If a child is distressed and if the situation is overall looking like it's a potentially stressful situation, I will have my intern step out. They can no longer observe. We need to minimize the people. And by using the one voice, we're able to calm that moment, have them focus on one voice. It might be the child life specialist, it might be the parent, it might be the physician. It really depends on the child and the family, but sometimes it's just the child and I, singing a song together, or me doing a countdown so that the child's coping strategies are supported and heard. But this is a wonderful approach that I think really makes the most quiet moments the most poignant. So, for example, here in the cardiac clinic today where I'm working, I would say my ECGs are the most quiet because it's usually just the child and I singing a song together. You know, it's a chance for us to be together and to focus our attention on one thing. Pain management, as I've explained, is an essential part of all of the things that Child Life does. You know, whether we're using something new and novel, like a numbing cream that provides, you know, pain relief at the site of an injection, or something like a new tool, like here, this is Buzzy. Buzzy is a vibrating toy. And if you are understanding of the gate theory, the brain and the pain, if you interrupt the link between the brain and the pain through a vibration like this, the brain focuses on the vibration and does not focus on the painful injection or the blood that is being collected. These links will provide you with resources that are specific to children and their pain management. They educate and can be shared with other professionals via these links. And I will assume Micaella's probably posted the links there too, if you need them. These are just effective tools that we have available to us. I do feel strongly, just like we've done at our hospital in Kenya, that it is important to create your own resources too, using others to help you. I think it's just a wonderful way for us to continue to acknowledge everybody's country, everybody's practice, everybody's institution is a little bit different, and it's okay to create your own resources. Oops, let me just get out of here. I think this happened last time too, where I just kept trying to go to the same link. There we go. Okay, let's look at distraction. This is one of my favorite parts of Child Life because the very first time I ever did an international Child Life visit, guys, I had my luggage stolen before I even arrived. And it was the best thing I ever had happen to me because I became a better child life specialist because I became the distraction. So this idea of diversional activities and distraction, you are not limited when you don't have access to toys. You can become the distraction, whether it's telling a story out loud, whether it's singing a song or doing something playful and silly like a funny walk down the hall with a child. You can be the distraction when you have no access to toys. You've seen the magic of that wonderful light up toy. Those light spinners that Liz and I love so much are really a wonderful, effective tool for distraction. They are very fragile and break often. I think Liz is probably nodding right now, but you're not limited to using those. Flats work. I mean, all sorts of wonderful things. My neck is a distraction itself. It's always got lots of toys on it. You know, whether it's building blocks, whether it's using technology, distraction is there at all times. I usually prefer to do some singing with patients, but that takes a lot of bravery. So if you're brave enough, I would highly recommend your distraction that you offer being singing. I did take some singing classes, so I can sing even better now. But staff education is also a step in the right direction. We always want to share and to educate others about the benefits of play, these child and family-friendly practices in changing a child's experience. You know, I think we all have strong opinions about what we're really good at and what we believe in and stuff, but change is always possible. And staff education, you know, modeling and showing. The reason why this presentation is so rich in photos is because it's one thing for me to talk to you about it, but it's a whole other thing for you to see it in action. Seeing children cope with procedures, seeing how a simple adaptation here in the corner for eye drops can change a child's experience. They feel well supported, they feel less vulnerable, they feel safe when they're having a hug and hold position further. Center here we have a few different books that I've created with patients and with my teams about different experiences, accidents, prosthetic eyes, coping, and medical play. And of course, in the corner here, you have our big chubby infant massage dolls, which are a wonderful way when infant is experiencing illness and hospitalization, for them to have positive touch during their healthcare experience, and it also promotes bonding between the staff and the families. Diversional activities, here's a huge amount of diversion strategies, these distractions that you can offer. And again, see, not all of them require you to use an actual toy. Counting can be done independently, deep breathing and mindfulness. Guided imagery is when you tell a story out loud and walk a child through an experience. Holding hands, utilizing comfort positioning. Today, my little friend with the language barrier, who is Greek, we held hands, we did special activities in the palm of his hand with no toys. And he was able to stay calm and complete the assessment with the cardiologist with no issues or challenges. You can play a game or watch a show. I tend to avoid screens as much as possible since play is really a much better vehicle for children's coping. But it is available. Engaging in conversation, asking a child about school or what their favorite food is, or their favorite color, song, experience, who their best friend is. All of these things are wonderful ways for you to get to know your patients and also provide a wonderful positive distraction. One of my anesthesiologists that I work with here at the hospital, he's an older man with white hair, but he loves to talk to children about their teachers and who their teachers are and his favorite teacher when he was young. And he tells this whole long story while we're getting ready in the operating room and he's putting the mask on their face. And the child is asleep before he's even finished the conversation, but he so joyfully presents this all about teachers and how important they are in our lives. So I want you to challenge yourself to think beyond a toy and think about the fact that you can be a distraction and that these wonderful interactions can offer respite for a child who might be experiencing some stress. Listening to music or singing a song. Athletes, football stars all around the world, soccer, tennis, everybody has music involved in their sport. And so I will often say to children, would you like a walk-in song when you're coming in to see the doctor or into the operating room? And we'll pick a fabulous song and we'll sing and we'll dance and we'll head in together. But all of these wonderful things can be done, with very little resources. Here's a few more. I Spy is a great game. I often will use environmental literacy in a hospital and say, like, I spy with my little eye, something that is red. But for children who are in the school system, I love to say, can you find all the alphabet letters as we walk down the hall together? And I say, let's start with the letter A. And then they'll find the letter A somewhere on a hospital sign. Now let's move to B. And you can offer this wonderful, whether it's counting, whether it's the alphabet, you can offer this wonderful opportunity to a child just while walking down the hall. Giving a job is important too. I will often say to kids, it's your job, to focus on this, or I need your help to create a beautiful poster for the wall. Giving a job just helps a child to feel extra special and that they might be giving back to the hospital. Closing their eyes, doing those deep breathing activities, playfully singing just out loud, not just with a recorded song, and then of course making your interaction playful. When I walk down the hall with children, I don't just walk normally, guys. I walk with a silly wiggle in my dance, or I hop like a bunny rabbit. We'll do whatever it takes to ensure that the interaction is playful. And then would you rather questions are really fun for older kids. Like, would you rather be able to swim like a shark or fly like a bird? And just giving them neat ideas and activities. Would you rather visit a snowy mountain or relax on a sunny beach? These would you rather questions are lots of fun, and I feel like teenagers and young children love to think about would you rathers. Processing through play. I want to quickly finish up because I know we have a little bit more time, but I'd like Liz to have a chance to talk to you and answer questions. Processing through play means allowing children an open opportunity to play, not just the preparation, but open play that's available to them at all times. So when children are given medical equipment, mix of real and pretend, and allowed to explore it on their own, they will often mimic what's happened to them in their healthcare experience. You'll see them practicing, you'll see them wanting maybe for you, the adult, to be the patient, and for them to explore and demonstrate their sense of mastery about what's happening to them in their healthcare experience. So these are spontaneous pictures that have been caught kind of in the moment. This is a young YU child working on another child in the hospital, helping explore and helping this young girl practice what will happen when she has a brannula placed. You can see he's taking her hand on his own. and he's continuing to complete his assessment with her. But this was just spontaneous. This wasn't facilitated. I think that that shows that the children are learning. Medication compliance is a lot of fun. I love it. There's some links here to these wonderful charts that my colleague and I have made that are playful ways that you can keep track of making sure that children know how to take their medications. It's a positive experience. It's keeping track. It's promoting that sense of mastery, and it's also acknowledging their hard work. So understanding challenges related to medication, like tastes, fears, and previous experiences. Often the most fun thing I love to do when I'm teaching a child how to take a pill, or we're transitioning a child off of a liquid and onto a pill, is that if they can chew, what's their favorite food is it, then we know they can swallow medication, and it's just giving them the confidence and the practice. So I typically use candy to help children learn how to swallow pills, just by starting with small sprinkles, and then we work our way up to larger and larger sizes. But children that are able to chew food are able to swallow medication. They just need an opportunity to practice, and a parent who's able to motivate and encourage them. So looking at those things, fostering development of new skills, and of course, developmentally appropriate education is the most important. And so we'll often have fun with stickers and practice, squirting the medication into our mouth on our own. Here we go. Let's finish up. One of the neatest things that Liz and I both are very passionate about too is supporting children of adult patients. Cancer, illness, and trauma doesn't discriminate. And so people of all ages are impacted by it. And so I will often do educational sessions for children when moms have been diagnosed with breast cancer, or we're dealing with an end-of-life case, and an adult may be dying and the child is living with that person while they're dying. Here you have some exploration of an MRI with my special Barbies that have removable hair. And so we talk about how mom might lose her hair, and that these are the assessments that she's having. And in a playful way, we deliver the same information we would to children who are experiencing the same assessments themselves. But in these cases, it might be a parent or family member. We also talk about and acknowledge worries. There's a little stuffed animal toy here that's called a worry eater, and we will help children talk about their worries out loud, like, I'm worried that my mom might die, and it allows us an opportunity to talk about feelings and fears, and again, dispel any misunderstandings or misinformation or myths they may have picked up by overhearing people speak. Also have some really neat activities here with Playmobil and Lego that allow children just to continue to build their skills about things they've heard about. This is a wonderful way to facilitate connection and also build memories of the person who may be dealing with metastatic disease. Here's some resources that I've created that you have access to. The Talking to Your Kids About Breast Cancer and the Metastatic Breast Cancer books are available for free online. You can access and download them there. The intensive care book that my intern Alex and I wrote during the pandemic, purchase on Amazon and any other book ordering purchases. And I'm hoping that one day when I get to come tonight and meet all of you, that I'll be able to give you some copies of these books. But it shows the intensive care environment and the hospital, and encourage children and families to be familiar with the sounds, the sights, and the different people that they would meet in the intensive care unit. Oops, that keeps doing that. Every time I switch the page, guys, it keeps taking you to there we go. Let's see if we can get out of here. There we go. So the worry eaters as well. This is a video link, which we can make available to you. But these are the worry eaters dolls that are available online for purchase that allow children an opportunity to talk out loud about their worry and feed it to the doll. This doll is just a nice way for us to openly discuss worries and also give children a chance to take that worry off their plate to help them to feel less stressed. I'm not going to worry about showing you the video right now, guys, but Micaella and I can make it available to you at a later time. I think this is an important part that we don't want to miss out on, but grief and bereavement whether it affected and we knew a person was actively dying and we had time to prepare, or a sudden loss, often will mean that child life specialists do these special legacy activities like hands, thumbprint charms. I do three-dimensional casting of a child or an adult's hands or feet when there is a death. And also, this is a family tree in the corner here with each family member's thumbprints all together with the person who may be dying or has died. It just is a chance for the families to have that piece, like a beautiful piece of artwork that acknowledges the person that they've lost, who has died. But these are just some examples of different type of legacy building activities and special tokens that we create. When a child is dying, I always want to talk about, and some of the chapters that I've written in books are about how when a child is actively dying, we really want to be focused on the living and what they need while they're with us. So we don't mourn them before they've died. We want to celebrate their life every day. And so when children's ability is less and less, and they're less and less able to do things like get out of bed, to walk, ambulate, or move, we will adapt the play for them. So in the first picture, you have a young girl in Kenya working with my intern, Micaella, and Micaella is coloring the coloring page as the child directs her. I want us to use this color here. I want us to use that color there. Because playing for a child still gives them that joyful experience. In the middle, you have a child playing the piano with the only hand that he's able to control now at the end of his life. And then in the last picture, we have an abandoned baby of ours with very profound hydrocephaly who was very infirmed, very, very much unable to move around. And so we provided infant massage and comfort holds. This is a resting hands position for her feed, just to make sure that is able to feel calm and well supported, even at the end of her life. Are we done? Let's see. Oh, we are done. There we go. Excellent, guys. I'm going to stop my share and I'm going to let Liz do a little chat. I'm also happy to take any questions. I see a few in the chat. Oh, thank you so much, Micaella, for posting everything.
Of course, and thank you so much, Morgan. I know we are soon to be out of time, so maybe Ms. Kabuthi, if you want to go ahead and share your screen, and simultaneously, if anybody has any questions, please add those to the chat at this time.
Thank you, Morgan, for that amazing and enlightening session. So good evening, colleagues. And as we begin, I would like us all to think of the human brain as a radio. If the only station playing is pain, the child hears it loud and clear. But child life allows us to change the channel. By engaging a child in an active multisensory task, we are essentially turning up the volume on a different frequency so high that the brain's gate actually closes to the pain signal. And so as we see child life continue to use what we call bubbles during lumbar puncture or a cannula insertion, we aren't just tricking the child. We are using the attention filter of the prefrontal cortex because the brain can only process so much information at once. Then if we occupy 80% of it with a high interest game, there's only 20% left for the pork. I don't know why it's refused to move. Okay, thank you. Yeah, so we are looking at the gate foundation. And then as pediatricians, we all know the damage of toxic stress. And by shifting the child from fear to the reward center of the brain, we replace cortisol with dopamine. And a child with dopamine in their system heals faster, operates better, and most importantly, doesn't develop the medical trauma that leads to them avoiding hospitals as adults. And so our goal as child life specialists is not just performing a procedure, we are protecting the nervous system of the children. We are looking at the sixth vital sign, which is the emotional safety of the children that we are working with. And so I'm not going to repeat this. Morgan has adequately gone through this slide very well. But I also want us to look at this case study of 5-year-old Chidi, who was admitted for severe malaria, dehydration, was screaming and requires for adults to hold him down. Imagine all of us in our ward round this morning. Was there a child who saw you in the white coat and they were so distressed? They were screaming. And as pediatricians, one time or another, you've been in this situation where you needed to work with a child, but they wouldn't stop to fight. If the child life specialist is given an opportunity for positioning, for distraction, as Morgan has talked about, then the clinical outcome will be amazing. We are going to ensure that Chidi is in control, he gains mastery, and will not be afraid seeing the doctor on the next visit. So play is medicine, and it has amazing outcomes. We want the children to play doctor, as we saw in Morgan's slides. We want to normalize environments, even if it is a small space, no matter how small. We can just put a small table that the children can run to when they come to the hospital, and to normalize the hospital environment to make it as friendly as possible. The use of colors, as you can see on this slide, whets the appetite of the children, and before they go to meet the doctors, they are calm, cool, and collected. They have had an opportunity for medical play. We have destigmatized the white coat. They've been given an opportunity to enjoy in the crafts and arts, and they are calmer when they meet the medical team. We also know that there is the white coat syndrome, and so we give the children an opportunity to dress up as doctors, walk around the hospital environment, go into spaces where we are preparing them for procedures, for example, MRI, CT scan. They can even go to the blood bank, supporting each other, so that when that procedure comes up, the children are well prepared and they know what to anticipate. Children learn best through visual aids, through doing, and so pretend play is really important for the children, and this is one way in which they are able to navigate hospitalization. We are talking about leveling play as a clinical strategy, and we all know, especially when we are working with children with life-limiting illnesses, they might regress. There's a bridge, the developmental gap, looking at the chronological age and the developmental mental age could be different because of the toxic stress. And so the child life specialist takes play to the child, be it in isolation room. We will provide opportunities for the children to be normalized. We play until the end, making sure that they are able to verbalize their emotions through play. Those children who cannot engage in running, playing ball, but they prefer to sit on the mat, that is exactly what is provided for these children. And music also happens to be an amazing tool for connection, especially for teenagers. So our key interventions, especially during procedural support, we want to avoid forced restraint, and that is why we are talking about positioning for comfort. This has been well tackled by Morgan. In this picture, courtesy of Morgan as well, is scene of a toddler who was going to the operating room, and we had to engage her in play so that she could understand what it means to have an oxygen mask on. Utilizing the age of development, what are we supposed to do? Engage them in a play, whether they are verbal or non-verbal. They will touch. Using their 5 common senses, the child is able to internalize what is going to happen in the procedure room. So the comfort position sessions are very important. We have several positions for comfort sessions because we are teaching the family members, the caregivers, to be co-coaches, to be partners in care. that when a child is supposed to go in for a procedure, the mother who is holding the baby must know that she should be a partner in this treatment team, that she should be there to support her child, be it singing, ensuring there's the one voice in the procedure room, and ensuring that the child is distracted so that they can be able to understand procedure well. Morgan talked lengthily about distraction. It's also my favorite. And I also wanted to add on the ABCDs of distraction. That is the use of assorted visuals. We also do a lot of breathing techniques. We do a lot of comfort measures and diversional talks. All these are geared towards alleviating the moment for the child. And the 4 Ws of distraction. The children would like to know, what is a procedure? What am I going in for? Is it a cannula insertion or an LP? Where is it going to be done? Which part of my body is it going to be done? Where is it also going to be done? Is it the bedside? Is it the procedure room? I remember last week in Nigeria, we were talking about keeping the child's bed safe as possible because we all realize that the bedroom is one of the most coveted spaces in our homes. And the same happens to children when they are in the hospital. The bed is their safest space. It is a place where they go to sleep their worries, their pains that have been accumulated the whole day. They eat on that bed, they cry, they laugh, they play. And so when we continue to offer or do procedures on the bed, considering our limited resources, then it means that the child will continue to have those nightmares or emotional pain even as it goes to sleep. And then they also want to know, when will it be done? Is it going to be done today in the morning or tomorrow? And then why it must be done. When children ask these questions and when we are able to answer these questions, the children become more cooperative and they are in control of the medical procedures. So Morgan talked about small talks, singing, using virtual reality, talking to the child so that the child's mind is taken away. Remember that the child's disposition is very important. There are children who would like to observe the procedure and they will benefit from small talk. For example, when you are putting in a cannula, the child will benefit from the doctor is going to wipe your hand with a cotton wool, then they are going to put a belt on your hand, that is a tourniquet, step by step. The child wants to observe. So the disposition of the child is very key. We need to assess the disposition of the child. So in this case study, I'm going to talk about 10-year-old Amina, newly diagnosed with sickle cell or disease. And she's withdrawn and refusing to eat. So what would be the intervention? We are talking about legacy or expression, allowing Amina to understand where is the pain, where is the challenge in my body. And for her to understand according to her 10 years, then we have to use different models, medical play, that the child is able to internalize. Children not only listen to our words, they have a very short attention span. So when we use models, they are better able to understand, internalize, and retain that information. And so after all this was done, the clinical outcome for Amina was that she had mastery over her illness rather than being a victim of it. And that is the goal. So the soft language that we use, in many times we find that we are forced to use threatening words, thinking that it will make the child cooperate. However, it makes the child fearful of the medical team, and they are also fearful of the procedure. So even the next day, when you ask a child to come in for a particular procedure, you will see a lot of fear, a lot of anxiety. They start becoming clingy, and they are in a difficult situation and therefore unable to cooperate as expected. So this is just an example of the soft language that we can use. Instead of injection, maybe we can use different words because it brings a different sensation. Maybe a word like a warm sensation. Instead of saying, hello?
think you can continue.
Hello, can you hear me?
Yes, yes.
Yes, we can
Okay.
continue.
So the soft language, the soft language that I was talking about is just to make the child understand the medical jargon in a very child-friendly way. So instead of holding him down, we can ask the family to give him a hug while ensuring that we make sure the connection between the child and the caregiver is maintained at all times. So in our procedure rooms or even in the wards, it's important that we have a distraction kit where resources are available. And that could be bubbles, it could be a music or toy. And also visual cues that can help medical healthcare providers to start learning new words. For example, often we use words like, do not cry. Why are you crying and you're a boy? Why are you crying and you're a grown-up child? Why are you crying and this small baby is not crying? That brings shame to the children. Instead of this, we can validate their feelings by telling them, in as much as they cried, you are a brave boy, this is good, you did well to hold your heart still. And that validates the child's feeling and they are able to communicate when they are feeling distressed to you. So legacy building comes in handy, especially when we know we have an end of life situation. Many times medicine looks at treatment, but I know that not often do we have this outcome. And so families lose their babies. We ensure that we can create tangible connections to help families create forever items. So in this slide, a colleague of mine is working on handprints for the memory book. We do a lot of stories, the children do a lot of stories, a lot of photographs that the family can remain behind with. This continues the connection that the dead child has with their family. Siblings are not forgotten because we know that many times siblings are forgotten when a child is in the hospital. So we try as much as possible to also include them in the goals of care. So the 5-minute implementation plan that we can all adapt, it is to assess what is a child's developmental age. And I know this happens a lot. What a child needs, a toddler's needs totally different from a teenage. Prepare, maybe we can use just 2 minutes before the procedure. Tell the child, what are you going to see? What are you going to feel? Using the 5 common senses of the children, let them know what it is anticipated. Through medical play and dolls, we are able to educate the children. Distraction, of course, we are going to use a tool. And when we don't have any resources for distraction, we can use our bodies. We can use our voices to sing, to reassure the child, to ask the child to look around the room, mention how many windows there are in the room, or what color of clothes anybody is wearing. That is also another mode of distraction. And validation is key. Let's continue validating the feelings of our children because that is one way we can win them over. So as I come to the end of my presentation, I would like us to take a pause and think about the power of presence. That even in moments when we feel there's nothing further that we can do, there's always something that we can do, and that is our presence. Our presence can be more healing than words or actions. And in fact, for children, they most often will remember how we made them feel, not what we did or we said. We might use medical jargon or because we may not be able to understand the children's developmental age or their needs, we may use powerful language unknowingly and cause a lot of harm to the children. So our presence, we can offer silence, we can offer empathy, and above all, shared humanity, especially when these children are dying from their diseases. So this is the team in the Moi Teaching and Referral Hospital. We wear a lot of bright colors, especially the primary colors are so attractive to children. And we also ensure celebration of significant days in the calendar. And all this is just to bring cheer, well-being, beautiful thoughts to the children to make them happy and for them to look at the hospital as a different space. Child life is a developmental science. And so every time we work with the children, let us remember What is their mental age as a chronological age? Where are they development-wise? Has the medical disease hampered their understanding? Has it hampered the way they are processing things? And then work with them according to that, reminding ourselves that children will always remember how we made them feel and not our words. Thank you.
Thank you very much for that presentation. We appreciate you. I think the session is now open for questions. We've gone beyond our scheduled time for presentation, so we could look at I'm looking at the chat room, and people can raise their hands so that the presenters take at least some questions and then they can give us the feedback. So anybody in the panel for questions while I read what we have in the chat box? So at the chat box, initially we have comments, if it's fear or anxiety or coping mechanisms for the children. And then okay, we want to hear about, we know you have been doing some work at the University of Abuja. We were hoping to get an insight because we're pediatricians practicing in Nigeria. Just maybe about 2 minutes, what you were doing, your perception about how we can implement this in our clinical practice from a home base, just to give us more insight. Unfortunately, the local Abuja team, they're in the West African College exam, so they can't come up. But I had a chat with Dr. Offiong, who says it's just starting. So I know it's still early, but if you can give us a bit of feedback, if there are differences from Kenya and Nigeria, just your experience in University of Abuja, what the work you're doing.
Okay, thank you very much for that question. Yes, I had a visit to iECHO last week, and the first thing that came to my mind was the enthusiasm by the healthcare workers in iECHO. And that is what we require. Having people with passion can be champions, and they can begin from where they are. Lack of resources should not be an inhibitor, but rather it can instill in us the opportunity to begin from where we are. I know there's a beautiful playroom, there's already space that can be used, especially in the pediatric oncology unit, but even in that basic clinic, in the pediatric clinic, we can always do a small table, offer paper activities just to normalize the hospital experience. So yes, there's a place where we can always begin in small ways, baby steps, and then to the larger outcomes in the future. Thank you.
Thank you. Any other questions from members? I can't see any hand. PE, are you available for a closing remark? Dr. Letu? Yeah, he said he may not be available. So I want to thank your group for teaching us and enlightening us at this webinar, integrating how to integrate child-like practice in our pediatric care. Just listening to what the program is all about. There are different specialists, not necessarily the physicians. We may need to get more professionals to be able to step down this practice and make it practical in our healthcare centers. In the absence of any other presentation, I want to thank us all for logging in and learning about this child life specialists and how to improve the experience of our children going through different types of diseases. And thank you and goodbye. Okay, there is a hand up. Lillian Ekwem.
Yes,
Sorry.
good evening, everyone. Thank you for those beautiful presentations. I actually asked a question in the chat box. I was asking whether it will be the same pediatric team handling these children that will also carry out this type of therapy of preparing children for procedures and treatments? Or will it be a separate team, that is trained for this type of treatment or approach to children? Because sometimes we have so much work, few hands doing a lot. And I'm just wondering if the same team will have to, spend this much time in, preparing children. It's a very, very beautiful idea, and I really like it. But I'm just looking at, the reality on ground. How feasible will it be if it's the same team that will do this, with the children, or there should be a special team created to handle this, please? Thank you.
I think one thing I'd like to respond to Lillian's question, and I know Liz will agree, is that what we've been doing in launching the profession of child life in Kenya has taken the last 18, 19 years. And that a small spark is all it takes to get started. So, whether that's you adopting aspects of this presentation of these child and family friendly practices, it's just the beginning. But the ongoing and continued learning and the practice of building the profession and hopefully eventually a child life team is happening now.
Okay. All right. Thank you. I think we'll start from somewhere. We should just start and gradually, we grow, and then eventually we might have a special team to handle this particular way of managing children. Thank you so much for opening our eyes to this aspect. Thank you. Really appreciate it.
And Micaella said there was also a team of social workers, physiotherapists in attendance at the Abuja team. So it's a because it's so that's
multidisciplinary approach.
Multidisciplinary, but I think by the time they train like some child life specialists, there will be an addition to the healthcare team.
Exactly.
Just to make it easier to implement at our local hospitals.
Yes,
We really thank you,
thank you so much,
Micaella, and I'm trying to get your name so I don't want to miss it. And Morgan, thank you so much. We appreciate you. You started a light in us, and we hope to move it forward. Thank you. Thank you, everybody. This is the end of the webinar. Yeah. All right then. Bye.
Thank you and bye.
Thank you. Okay.